We will have the presentation from Medicine 5. Tephilah will be presenting. Journey to the Brain is the title of the.
Good morning, everyone. I'll be presenting on behalf of Medicine 5. The title for my presentation is Journey to the Brain. So presenting Mrs. S. She's a 35-year-old lady from Andhra who presented with history of swelling over the left supraclavicular region for 4 months, loss of appetite and weight. She lost around 5 kgs over 3 months. There was also a history of fever for 15 days. It was low-grade intermittent and there was no diurnal variation. There was also lower back ache, which was dull aching for 15 days. And there was a headache for 3 days. It was holocranial and it was severe, and there was photophobia associated with it. And she also had multiple episodes of vomiting, which she presented for 1 day. It was non-bloodstained, non-bilious, and it was projectile. Coming to the background history, in November 2020, she was diagnosed with sputum positive TB. So she had taken ATT for 6 months and she was fine for almost 2 years. Then in August 2022, she noticed a swelling over the left supraclavicular area. So it was tested outside and it had showed only granulomatous lymphadenitis. 1 month later, that swelling had become fluctuant and an ultrasound showed hypoechoic lesions, which were suggestive of an abscess. So considering the history of past TB and also a lymph node showing granulomatous lymphadenitis, they had come to a diagnosis of a TB abscess and they had started her on ATT. 2 months later, she developed thrombocytopenia and ATT was stopped. So with this history, she had come
Do
to.
Do we have a expert or midget?
It was not
sensitivity pattern.
It was not microbiologically proved. So with this history, she had come to our emergency department on the 9th of January. So she was a little tachycardic. She was pale, and she had multiple ecchymotic patches all over her body. Fundus examination showed papilledema, and there was neck stiffness. The rest of the systemic examination was not significant. So with the symptom complex of left supraclavicular lymph node swelling, loss of weight and loss of appetite, history of fever for more than 2 weeks, and history of severe headache with projectile vomiting with features of neck stiffness and papilledema. Does anyone have any differential diagnosis? So we've localized it's a systemic infection, systemic disease with there is presentation of CNS features. So our first differential was a disseminated TB with CNS involvement. One thing because of the history itself, and as because she had a past history of TB too. Second thing we considered was probable an immunodeficient state with a cryptococcal meningitis. We also considered disseminated malignancies and also primary hematological malignancies. And lower down on the list, we thought of autoimmune diseases. So coming to our investigations, her CBC showed bicytopenia. So there was low hemoglobin as well as low platelets, and there was deranged LFTs. The liver enzymes are elevated. So we did a brain imaging because we suspected a chronic meningitis, which showed features of raised ICT, and there was leptomeningeal thickening and enhancement. So if we see this image, there is the white thing on it's a T1 weighted image with gadolinium contrast. So the white hyperintense lesions are the leptomeningeal enhancement. And we also found that there were T2 hypoechoic lesions in multiple areas of the vertebral body. So we wanted to go ahead and do a CSF analysis on her, but we couldn't because she had thrombocytopenia as well as raised ICT. Her platelet levels had fallen down to around 9,000 during the stay. Because she had a left supraclavicular lymph node, we wanted to look for other lymph node involvement and organ involvement. We did a CT, thorax, and abdomen. So what was interesting was there were features of lymphangitis carcinomatosis in the sense that there was interlobar thickening of the septum in both the lungs. There was minimal pleural effusion and there were multiple lymph nodes. We did a bone marrow because we suspected a bone marrow infiltration because she presented with bicytopenia, and that showed a necrotic marrow with metastatic adenocarcinoma. So we wanted to find out where the primary source was, and we did a gastroscopy, which showed an ulceroproliferative lesion along the greater curvature of her stomach. So coming to a final diagnosis, it's a disseminated adenocarcinoma with a primary stomach cancer as probably the primary cause. And she had presented with initially bicytopenia, but in the ward she also developed leukopenia. She had lymphangitis carcinomatosis, and she actually clinically presented to us with features of leptomeningeal carcinomatosis. And there were also multiple vertebral metastasis and lymphadenopathy. So because she presented with a history which was suggestive of a leptomeningeal carcinomatosis, I'd just like to cover briefly upon it. So what exactly is this? It's when the malignant or the neoplastic cells, they get seeded into the meninges or the subarachnoid space or the CSF. So earlier it was initially described more than 200, 300 years ago. So how they found it was they uh, did autopsies on cancer patients, and that's how they found out that there was something called leptomeningeal dissemination. So coming to what kind of cancers metastasize to the meninges, the most common causes were breast cancer, lung cancers, and melanoma. GI as well as adenocarcinoma of unknown origin were also in the list. So how do they spread? One is either they spread directly from either the dura or the brain parenchyma. Also, they can have a hematological spread. So they can spread through the arterial or venous plexus, or they can have a centripetal spread. So they spread from the nerve roots. They travel via the endoneurium or the perineurium, and they enter the meninges. So this is what I'd like to mainly focus on, how they clinically present. So if it involves the cerebral part, they can present with history of headache, confusion. They can also have cognitive impairments or seizures. So our patient had presented with history of severe headache. And if it involves the posterior fossa, where the cerebellum and multiple cranial nerves are present, they can also present with ataxia as well as multiple cranial nerve deficits. And if it involves the vessels, they can present with ischemia or infarction. Suppose it involves a spinal cord, they can present with radicular pain or any dermatomal sensory loss, limb weakness, or bowel or bladder dysfunction. And they can also cause inflammatory reactions that can cause obstructive features, causing hydrocephalus, which can present as nausea, vomiting, headache. So once we have a high clinical suspicion of a leptomeningeal carcinomatosis, we can confirm a diagnosis using an MRI or a CSF analysis. So MRI, I already mentioned earlier, they can show leptomeningeal enhancement, can present as hydrocephalus or multiple nodules. And if it involves the MRI spine, again, it can show enhancement of the nerve roots. So CSF analysis will actually show low glucose, high proteins, and CSF cytology is also required. One thing to note that even if a cytology is negative, it doesn't mean that there is no leptomeningeal involvement. So we have to repeat a large volume CSF of around 10 ml. So these are just other features. Basically, there's leptomeningeal enhancement, multiple nodules, and this is just CSF cytology studies. So coming to the treatment is just beyond the scope of my presentation, but I would just like to say that you can give systemic chemotherapy or intrathecal chemotherapy. Radiation is also a possibility. And to relieve pressure in the, like if there is presence of hydrocephalus, we can use reservoir bags to relieve the pressure. So coming to the prognosis, it has a very poor prognosis. So studies say that once it's a diagnosis of leptomeningeal metastasis is made, the average survival time, if it's untreated, is less than 3 months, but it also depends on the type of cancer. So coming back to our patient, she was admitted with us on the 9th. She developed leukopenia also in the ward. Her platelets had fallen to 9,000. Her HB had dropped to 5.5. She also developed multiple fever spikes. And she also developed drop in sensorium, and a repeat imaging showed raised ICT. which was worse than the previous one. So she was symptomatically managed with anti-edemal measures. Also, she was given product transfusions. And finally, when the diagnosis was made, she was transferred to medical oncology. But before any plan of chemotherapy could be made, she passed away 3 days ago. So I just like to say that it has a very poor prognosis. So coming to the learning points, I would just like to say that like how a patient had presented, we need to know how a leptomeningeal carcinomatosis can present, and just a brief on the modes of spread and diagnosis.
Thank you, Tephilah. A couple of questions about the history and physical examination findings. So the first diagnosis of tuberculosis was in 2020.
20.
Pulmonary tuberculosis. Was a microbiological confirmation?
It was microbiologically confirmed. I'm not sure about the sensitivity.
But she took 6 months of treatment and she went back for follow-up and they told you're cured. So her symptoms had improved. Okay. Then within 2 years, she developed a lymphadenopathy in the left supraclavicular region. And histopathology was a granulomatous inflammation.
Epithelial cells and macrophages.
Sir, actually, we reviewed the FNAC. There was just some one histocytic aggregation, which was otherwise this is an outside, but the biopsy report that we saw, they gave from there actually said granulomatous inflammation. But when we reviewed it, was basically just a single histocytic aggregate and very, so that's what I heard. So it was.
But even when we reviewed, there were no cancer cells in the FNAC.
But it was an FNAC.
And within a month, it became an abscess.
I'm not sure. We never saw that swelling. So there was a swelling definitely, and the swelling maybe they excised it, but it was not there. There was no lymph node.
And she had this additional finding of thrombocytopenia, unexplained thrombocytopenia.
That came a few months later, and they had assumed it was a reaction to ADT and stopped ADT, and then she came 1 month later.
And she's HIV negative and she's not known to be immunocompromised. So the first question to ask is that following successful chemotherapy, how often does TB relapse or recur? Does it occur at all?
Can.
Does occur. So even in successful chemotherapy, you can. And how often does it happen? How soon does it occur? So it's less than 5% and most of it occurs during the first 2 years of follow-up. So that itself should have given you, it's a rare event. Somebody who was successfully completed, provided that chemotherapy was adequate, appropriate, and she completed treatment, that itself should have given you. And she had disseminated cancer. She had cancer everywhere now, in the lungs, in the lymph nodes, in the bone marrow. So it's not just carcinomatous meningitis, she was spread all over it. But good that you made the diagnosis. Okay. Any other questions or comments? Okay. Thank you. Next is a patient David is going to present from Medicine Unit 2. The title of the presentation is Hidden in Plain Sight.